Well, hello there, and welcome to the second part of trauma. This is your flail chest. If you notice, there's a number of broken ribs, and they're broken in two or more places. This is the reason why you lose that chest wall integrity that we talked about with broken ribs the last time. So what are some of the signs and symptoms? You have paradoxical chest movement, lots of respiratory distress. These people are unable to breathe, and they're unable to breathe because their chest wall is going the opposite way. They're going to be cyanotic because they don't have oxygen that's being exchanged. They grunt. That grunting is designed to hold the gas in their chest and to help hold as much of that lung open that they can do it. It's really kind of unusual for us to hear adults grunt, but they do. We see this with babies who are in respiratory distress. We also see nasal flaring with babies in respiratory distress. So it's really kind of unusual when we also see that with adults. They do use accessory muscles and they are in severe pain. So what do we do with this? We're going to use stabilization. They don't use tape as much as they used to, but you can use sandbags and towel rolls. A lot of times we're going to go ahead and intubate and mechanically ventilate them, give them some PEEP or give them some CPAP to help hold the lungs open at that particular point. We're going to place the injured side down, and the reason we're going to do that is we're trying to stabilize it. If we flip that injured side up, we're going to lose the gas exchange that we would otherwise have. IV and oxygen, some pain control is what we're going to do. And one of the things that you need to be aware of is a chest x-ray is less sensitive than CT for the diagnosis of Flail segments, okay? So you just got to be aware of that. We talked about the first rib. Remember, if the first rib is broken, that it is severe chest trauma at that point. Some of the things that go with it, about 10% of people who have the first rib have an aortic transection, and about 2% are going to have bronchial tears. So we need to be very aware of what's going on. This is how they used to treat flail chest. You can see the springs up at the top here. At this point, pulling the rib out, so you're keeping the chest wall open. And then here we're going to go ahead and we're going to push it in and hold it in place and stabilize it. And then you can see with this, you're going to have some problems with a lot of atelectasis. And this is an x-ray, and you can see with the arrows are showing you where the breaks are, and you can see a lot of infiltrates that are going with this also. You can also have just rib fractures, and the most causes of these are motor vehicle accidents or blunt trauma. Your chest wall is going to protect whatever the viscera is that's underneath, and your fractures normally occur at the point of impact or the posterior angle of the chest, because that's your weakest point. The question is, how do we treat rib fractures? If you need to, your CABs or ABCs, depending on the patient, what's going on with them, oxygen prior to getting to the hospital. We're going to do the chest x-ray, the angiogram, pain control, clear secretions. Occasionally you'll have crepitus, and remember crepitus is subcutaneous emphysema, and that could be because the rib has punctured the lung at that particular point. Cardiac tamponades, we talked a little bit about those. Pericardial tamponade, this can result from myocardial contusion. You're going to have blood in that pericardial sac. Here's your main hemodynamic consequence is decrease in diastolic filling and increase in our pericardial pressure. What's going to happen is that the fluid that's in that pericardial sac is now going to start to push the ventricle and the atria into the heart and not allowing it to move as well as it needs to. And at that particular point, you're not going to be able to get the blood back to the heart. You're not going to be able to get the blood out at that particular point. So this is cardiac perforation. This person ended up with a rib fracture that they had in a ram attack in New Zealand, okay? And the 72-year-old woman that this is a picture of presented to the ED having suffered this unprovoked attack by the ram. Okay. And she had obvious left-sided chest injuries, abrasions to her face. She was complaining of facial thoracic abdominal pain, and she was treated according to the Advanced Trauma Life Support Protocol in New Zealand. She was alert, conversing, although obviously in severe pain and distress. She was cardiovascular stable despite the left-sided flail segment, and she had multiple rib fractures also. Okay. And she had also a large hemopneumothorax, a large amount of surgical emphysema, and a fractured mid-shaft left clavicle at that particular point. Okay. So you can see the different things that went on with her. This is a myocardial laceration of the right ventricle. So what happens with this one? There's your decreased cardiac output, venous hypertension. Remember, all that blood is staying up in the vascular system. It's not able to come back to the heart. So you're going to see your central venous pressures increasing. Your heart sounds become more muffled and more distant because you have all that fluid now that's surrounding the cardiac cavity. Pulsus paradoxus, restlessness. People who are hypoxic or hypoxemic become very restless. And that's something that you need to keep in mind. Ogleria, anuria, and a very low voltage 12 lead EKG. We actually had a patient one time that the physician was with us. He was a really good cardiologist. And we were doing the EKG. It came out of the machine, and there's three of us looking at it going, I know we just did this EKG, but it doesn't look like you're printing anything out. When you looked at it closely, you could see that there was very tiny tracing at that particular point. Extremely low voltage EKG. So this was the same heart that you saw with the ventricular rupture. At autopsy, the pericardial cavity was open. There was 300 mLs of clotted and 330 mLs of liquid blood that gave this person their cardiac tamponade. Okay. And there you can see some of the blood that goes with it. So how do we handle this? Supplemental oxygen, of course. You need to make sure the airway is always patent. You're going to give some rapid fluid boluses. You have to figure out what is going on here. Pericardiocentesis. These are kind of interesting. What they basically do is they get like a 60 ml syringe. They get a great big needle and they go into the pericardial sac. This is probably not the person who goes, I've never done one of these before. Can I do it now? Because you don't want to hit the heart instead. The other thing you can do is a transesophageal echocardiogram, and unfortunately, look at that, your long-term survival rate is less than 10% at that particular point. Now, when they do the pericardiocentesis, when they pull that blood out of the pericardial sac, it's not clotted. Why isn't it clotted? Because even though the heart's not working well at all, it's still moving, and it moves just enough to keep that blood from clotting. Aortic rupture, this is your blunt penetrating trauma. You can see deceleration, shearing within the vessel, and compression against the vertebral column. There's 4 common points, and these are mainly up and around where the aortic arch is, okay? And if you think about the aortic arch, it's really not that well supported. It's just about there. Death, most of the time, you're going to see in 80 to 90% of the victims immediately. If they survive and they make it to the hospital, you're going to have about another 10% that are actually going to die once they get to the hospital. The survival rate, less than 5%. And you can see with this one, here's an x-ray. Some of the arrows are showing you where the blood is actually leaking out at this particular point. So you can see your mediastinal widening is your most common plain radiographic finding. About 80% of your patients are going to have that. What do we see? How do we treat this? Sometimes you don't even know what's happening. Sometimes there's severe chest and mid-scapular pain. They may tell you that they're short of breath, hypertension in the upper extremities. There's the widening of the superior mediastinum. You lose the aortic notch. There's that fracture of that first rib. always be suspicious of that first rib. Tracheal deviation to the right and deviation of the esophagus. So what are they going to do? ABCs, CBAs, depending on what the status of the patient, and immediate thoracotomy at that particular point. And this is an aortic rupture, okay? In the chest x-ray in this case, this was caused by a traumatic perforation of the thoracic aorta, okay? So we do see that some people will have abdominal aortic aneurysms, and we'll see the blood also up around the pericardial sac. And a lot of these folks that have the AAA actually complain of back pain, lower back pain. Myocardial contusion, sometimes this happens with car accidents, CPR. We actually had a patient who ended up with one of these. He was at one of the stores that sell lumber. A piece of lumber came down and it smacked him direct in the center of the chest. And he was sitting there going, "Can I go home?" And they're going, "I'm not quite sure." Okay. So there you can see it is a compression of the heart between the sternum and the vertebrae. There is physical bruising. You have a lot of small petechiae to large contusions, and then you can also have some necrosis of the myocardium. And we're going to see bleeding and edema where the injury occurred. There's going to be chest pain, sinus tachycardia. You do have some arrhythmias that go with it. We're going to treat it the same as an MI. We're going to give you oxygen, IV for fluids and things like that, lidocaine, and then possibly keep you in the hospitalization. They kept this person for 48 hours because they weren't quite sure how bad his edema was going to get. Pulmonary contusion, you can get this with a blunt thoracic trauma. It can be associated with that flail chest. You can see the three components there: pulmonary edema, interstitial hemorrhaging, and atelectasis. And you're going to also be systemic hypoxia. The interesting thing, this doesn't happen that often, but it is the most common potential life-threatening injury in America. And this is a picture, and it shows you there's your edema, your hemorrhaging, and your atelectasis all occurring in the lobe. Interesting at that point. You've lost your vascular markings, so you have something going on over here, but you can also see that there's some pulmonary contusion, and here's an opening at this particular point also. So what are some of the signs and symptoms of this? Dyspnea again. Remember, dyspnea is the patient telling you that they are short of breath. They're going to be tachycardic, anxious, you have crackles, wheezes, cyanosis because you're extremely hypoxemic. The biggest thing is those x-rays. If you do the x-rays right away, you're not probably going to see that injury. You really need to wait that 48 to 72 hours, and then we can go ahead and see where those injuries occurred. So what are we going to do? Oxygen, adequate ventilation, chest physiotherapy, a little fluid management. We can't afford to have much fluid on board. Pain controls. And then we're going to end up down here if you have signs of respiratory failure with a PaO2 less than 60 millimeters of mercury on room air or less than 80 on supplemental oxygen. Means that you're not oxygenating well at that point. The diaphragmatic rupture. This is your blunt or penetrating trauma to the lower thorax or upper abdomen, most commonly on the left side, because what's on your right side? Yes, the liver. And so it's harder to get to the diaphragm at that particular point. So what happens with this diaphragmatic rupture? Got a lot of pressure. We forget that we have a lot of pressure in the thoracic cavity. We have a lot of pressure in the abdominal cavity. And if you make an opening, that pressure is going to be released, and we're going to carry the viscera right through that opening into the thoracic cavity. So this is a picture of somebody who has a diaphragmatic tear. You can see there's still some part of the viscera still in the abdominal cavity, but you can also see a lot of viscera in the thoracic cavity. You can see how things have been pushed around over at that particular point. Now, one of the problems that you have is that hole doesn't have to be that big, or that opening doesn't have to be that big, and that viscera is going to start to be compressed, and then it can also start to necrose and turn into gangrene. So you really got to get it out of the thoracic cavity as soon as you can. And this is a post-traumatic diaphragmatic tear with the stomach herniation. So what are the signs and symptoms? Sometimes you don't know it, other times severe distress. You can have abdominal or chest pain. Again, you're going to be cyanotic, a paralytic ileus. You're listening for bowel sounds. You're not going to hear those. You're also not going to hear any breath sounds because you've compressed that lung, so there's nothing going on at that particular point. A scaphoid abdomen, if you look at your stomach and your abdominal cavity is sticking out. If everything is going out of it, now it's coming back in, okay? And then, of course, the mediastinal shift. There you see, that's another picture of it. So the treatment, for the most part, ABC, CAB, depending on where the patient is, ventilation, intubation, gotta get them on mechanical ventilation into surgery to fix that. The tracheobronchial disruption is basically very rare, okay? However, they really have to be suspected in patients with blunt or penetrating injury to the neck or chest, especially if there's external evidence that something has happened there. There's going to be some pain, ectomosis, swelling, things along that line. The incidence of having a tracheobronchial disruption is about 0.5 to 2% of patients with blunt trauma and 3 to 8% of penetrating cervical trauma. Okay, patients with complete traumatic tracheobronchial disruptions have a high mortality rate and often die before they ever make it into the ED. In one study, 78% of the patients died in the field and 21% of the patients died within 2 hours of hospital arrival. Doesn't happen that often. High mortality connected with it, okay? You can see it only occurs in 1.5% of all trauma victims at that point. So what happens is the air is passing through the tear to the pleural space or mediastinum. There's your pneumothorax or your subcutaneous emphysema, and you're probably going to have to go ahead and support these folks. Now this is called and I'm going to show you on the next X-ray, on the next picture, X-ray, the following sign of CUMP, K-U-M-P-E. And what we are seeing here, though, is with the tracheobronchial disruption, there's the opening. And you can see the air coming in, and now you can go ahead and put that double lumen ET tube in there and protect it at that particular point. So this is called the fallen lung sign, which is often called the falling sign of CUMP. Basically, it's a collapsed lung in a dependent position hanging on the hyaline only by the vascular attachments. When you're looking at the pneumothorax, you can see the lungs are pushed up and over and they're being held in place with all the air. With this one, the lung is coming down and being pushed out, okay? Okay, so these arrows, the black arrows are pointing towards your lung. The white arrows are pointing to the outside portion of it. You can see there's some there's some air at that particular point as far as that goes. Hemoptysis, respiratory distress, there's your subcutaneous mediastinal emphysema. You've got to intubate, do the bronchoscopy. You're going to do a chest tube for that pneumothorax. If they have a hemothorax, you're going to do a second chest tube for them, and you have to repair that area. So you can see with this is a little bit better one than I found. You can see the falling sign. The lung is pushed down and out. We can also get esophageal perforations. Most of the reasons you don't know, but it happens. You do not want your gastric contents or its bacteria in the mediastinum. Otherwise, you're going to end up with some fatal systemic toxicity. You're going to go into hypovolemic shock. You're going to end up with subcutaneous emphysema. You're going to end up with a fever. Got to get you into surgery. Got to get you antibiotics, take care of you that way. And there you can see this is a lot of gastric content that's sitting in the lung cavity. In chest tubes, 3-bottle system. We used to have 1, with 2, now we have 3, and we have the Pleurovax that you can see. The tube, for the most part, we're going to set the pressure like negative 20 centimeters of water pressure. However, if it's a big opening, they can set that pressure much higher. So don't be surprised if you may see something like that. We have to be careful because if this person's on a ventilator, we're also going to have suction set up. And sometimes what happens is you can set up two suctions to one suction container. And in that case, you always want to make sure you know what you're messing with. You have to start and figure out, where's the chest tube, and follow the chest tube back to where the suction container is. And then follow our suction back to the wall also to see where it is, because you don't want to be increasing that pressure from a -20 to a -120 at that particular point. So always watch that, okay? Now, one of the questions that comes up is you get a person who walks into a patient's room, they walk into the room, they kick over the Pleurovac, it breaks. Now the patient has no suction. What's going on at this particular point? The answer is very simple. Go get yourself a glass of water, submerge the tube in the glass of water. That will give you your suction level until you can get a new Pleurovac set up. Okay, so just be aware of that. One thing with chest tubes too, you never shut off the chest tube, the drainage portion of it. If you shut it down and say, well, we're just not going to have anything happening at this point, all that air is now going to go back into the lungs, and now you're going to reestablish that pneumothorax or whatever else and make it much, much worse. So there you can see how the suction is set up, okay? And that's the Pleurovac. And you have your water seal in this area. Remember, if you have constant bubbling in a water seal, that means that you have a leak, okay? If you have no bubbling, that means that there's a problem somewhere. It could be occluded, there's something else going on. And there's your trocar in the back, and there's your chest tube, okay? If you go in and you're taking care of a patient and the patient doesn't look quite right, take a look at that chest tube and make sure all those little holes on the end of the chest tube are still in the chest. Now, when they take the chest tube off or out, basically what they're doing is they're going to take a petroleum gauze and put it over, because they don't want any air going into the chest. We actually had that happen to a patient. They had pulled his chest tube out. They forgot to put the petroleum gauze on it. Probably about 2 hours later, he was in his room screaming at the top of his lungs. He was in so much pain. He finally ended up about 11:30 that night. He ended up in the ICU. 3 o'clock in the morning, they pulled off like 1.5 liters of fluid off of his chest. And this is a pretty cool x-ray. I normally try to show that to the students. So what I need you to do is take a look at this x-ray and tell me if you see anything unusual about it. It's a pretty good one, okay?